Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the connective tissue disorders, that is the Sjögren syndrome. So, if you see the definition of the Sjögren syndrome, it is a systemic autoimmune disorder. Right? So, autoimmune disorders are those where there is antibody formation against the own organs of the individual. And here the antibodies, they are formed against the lacrimal and as well as the salivary glands. Okay, so that is what you will see within the Sjögrens. Now, because of the antibody formation against the lacrimal and as well as the salivary glands, there will be dryness of mouth and as well as the dryness of eyes. So that is a characteristic feature that you will see in patients with the Sjögrens. So please remember, Sjögrens, it is an immune mediated disorder, or it is due to immune dysfunction. Right, it is due to immune dysfunction. That is what is your Sjögren syndrome. And if you see the age of the individual with Sjögrens, first of all, being an autoimmune disorder, it is most common seen in women rather than men. Okay, and almost the ratio is in 9:1. Right, it is predominantly seen in women with a ratio of 9:1. And the age group at which you see this particular Sjögrens is around 40 to 60 years. Right, the age group at which you will have this particular Sjögrens is around 40 to 60 years. Then, if you take this Sjögrens, we have two forms of Sjögrens. One is primary Sjögrens and the other one is the secondary form of Sjögrens. See, the primary Sjögrens, it occur in isolation. So what does that mean? It means that in case of primary Sjögrens, you have only Sjögren syndrome, right? And it is not associated with other autoimmune disorder. That is what is your primary Sjögrens. So in primary Sjögrens, there is no other autoimmune disorder. Okay, then if you see the secondary Sjögrens, it is most frequently associated with other connective tissue disorders or other autoimmune disorders, right? Associated with other connective tissue diseases, and out of which most commonly, it is associated with rheumatoid arthritis. Right, most commonly it is associated with rheumatoid arthritis. Okay, and not only rheumatoid arthritis, it can be associated with SLE, scleroderma, polymyositis, other autoimmune disorders like Hashimoto's thyroiditis. I will discuss that in detail, but for now you just see primary means only Sjögrens, there is no other associated autoimmune disorder, whereas secondary Sjögrens means it is the one which is associated with other connective tissue diseases or other associated autoimmune diseases. Now, you see a question here. Sicca syndrome is associated with all except midline granuloma, chronic active hepatitis, rheumatoid arthritis, scleroderma. Right? Now, we will discuss in detail about this Sjögrens and then we will come back to this question in the later part of the discussion. So, first of all, if you see the pathogenesis in Sjögrens, so you need to know that Sjögrens, it is a chronic disease. Right, it is a chronic disease. Now, when you call this particular Sjögrens as a chronic disease, what are the cells of inflammation in chronic diseases? It is the lymphocytes. So, we have discussed in the beginning also that it is immunologically mediated disorder. Right, it is immunologically mediated disorder. Okay, which one? The Sjögren's. It's a chronic disease which is an immunologically mediated disorder, wherein the CD4 plus T lymphocytes, right, CD4 plus T lymphocytes, they get infiltrated, right, they get infiltrated into, right, they get infiltrated into lacrimal and as well as the salivary glands. Okay, so this particular CD4 plus T lymphocytes which will get infiltrated into the lacrimal and as well as the salivary glands, they will cause the destruction of the glands. Right, they will cause the destruction of the glands and as well as the fibrosis of the salivary and as well as the lacrimal glands. Okay, now you need to know what are the antibodies. So I said you that Sjögren's, it is an autoimmune disease. So the autoantibodies that you will have in Sjögren's is SSA and as well as SSB. Now this SSA, another name of it is anti-Rho, whereas SSB is anti-La. So these are the antibodies that you will have in patients with the Sjögren's. But please remember, very important point, these antibodies are seen in up to 90% of patients. Right, these antibodies, they are present in up to 90% of patients. Alright, next. So I said that Sjögren's, it is in two forms. One is the primary form, right, one is the primary form which is an isolated disorder. Then we have the secondary form, right, which is associated with other connective tissue diseases or other autoimmune diseases. Now what I will do, I will discuss in detail about this secondary form. Let me tell you what are all the various disorders associated with Sjögren's. That includes rheumatoid arthritis. This is also an autoimmune disorder, and the autoantibody is your anti-CCP. Then SLE, right, in SLE we have many autoantibodies, out of which the most specific will be anti-Smith and most sensitive will be anti-nuclear antibody. And scleroderma, right, so this scleroderma also, it is of two forms. One is limited cutaneous scleroderma and as well as the diffuse scleroderma, right, and this is also an autoimmune diseases. Then another important autoimmune disease is mixed connective tissue disease, right, where the autoantibody is anti-RNP. Then the other disorders that can be associated is primary biliary cirrhosis, right, primary biliary cirrhosis, then followed by that vasculitis, next chronic active hepatitis. And there can be even association with Hashimoto's thyroiditis. So these are the other autoimmune disorders that can be associated with the Sjögren's. Now, if you see the clinical manifestation in Sjögren's, so we have discussed that the age group at which you see commonly Sjögren's is in older women, that is around 50 to 60 years. And symptoms, whatever you have, is mainly because of the inflammatory destruction of, right, that is CD4 plus T lymphocytes, inflammatory destruction of exocrine glands, right, and what are those exocrine glands? That is the parotid gland and as well as the lacrimal glands. Now, because of the inflammatory destruction of the exocrine glands, the individual can produce the keratoconjunctivitis sicca, right? That is nothing but the dry eyes, right? That is nothing but dry eyes. So the ocular symptoms, they are usually mild. In early stages, the ocular symptoms will be mild, and that ocular symptoms will be in the form of burning, and that ocular symptoms will be in the form of the itching sensation, right? And these ocular symptoms can be in the form of sensation of foreign body in the eye, right? That is in the form of sensation of foreign body within the eye. And for some patients, the initial manifestation is inability to tolerate the wearing the contact lenses. Because of the dryness of the eye, the individuals will have inability to wear the contact lenses. They cannot tolerate that. Okay. And the next point is, many patients with some severe ocular dryness, they notice ropey secretions across their eyes, right? They notice ropey secretions across the eyes, but this is seen in those individuals with severe ocular dryness. And this ropey secretions within the eyes, they are especially seen in the morning, right? And for most patients, the symptoms of dryness of mouth, they dominate those of the dry eyes. So symptoms of dry mouth, they dominate over the dry eyes. Now, so that is about your ophthalmic manifestations, that is xerophthalmia. Then you take xerostomia, that is dry mouth. So because of dry mouth, the individual will have difficulty in swallowing the food, right? Difficulty in swallowing the food, and there will be dryness of, right? There will be dryness of the buccal mucosa, right? There will be dryness of the buccal mucosa. And another very important point is that some of the patients, they frequently complain of cotton mouth sensation, right? They complain of cotton mouth sensation, and especially the dry foods like crackers and all, they cannot swallow, right? They complain of the cotton mouth like sensation. And this persistent oral dryness, they cause most of the patients to carry water bottles or other liquid dispensers from which they have to sip frequently. So they have to take water frequently or recurrently. And these individuals, they also have difficulty in speaking, because for speaking we require adequate amount of saliva. And because of the severe xerostomia, they have even difficulty in speaking as well. And persistent xerostomia, right? Persistent xerostomia, it results in development of dental caries, right? Development of dental caries. And particularly if you take caries at the gums, right? Particularly if you see the caries at the gum line, this is strongly suggestive of the Sjögren syndrome, right? This is strongly suggestive of Sjögren syndrome, right? And some of the patients, they are troubled by loss of taste and as well as the loss of smell. And not only dryness in the mouth and as well as dryness in the eyes, there can be also dryness within the nose, throat, larynx, bronchi, vagina, and as well as within the skin. So these are all the areas where there can be presence of the dryness. And there is infiltration of your CD4 plus T lymphocytes, and because of which there is parotid gland enlargement. And this parotid gland enlargement, it is seen in almost 50% of the patients. And this parotid gland enlargement, it is chronic, right? It is chronic or relapsing, and it is seen in almost 1/3 of patients, or like almost half of the patients you have this parotid gland enlargement. Then followed by that, what are the systemic manifestations in Sjögren's? So if you take the systemic manifestations in patients with Sjögren's, that means it is like extraglandular manifestations. That extraglandular manifestations that the individual will have is, one is dysphagia, that is difficulty in swallowing, is mainly because of decrease in the salivary secretion. But the other features like small vessel vasculitis can be seen. So you have to remember that in Behçet's disease, the individual will have large vessel vasculitis, but in Sjögren's what the individual can have is small vessel vasculitis. Respiratory manifestations, that is in the form of pleuritis and obstructive airway disease, right? Pleuritis and obstructive airway disease. And there can be also development of interstitial lung disease as well. So these are the respiratory manifestations that you will have in patients with the Sjögren's. And there can be even neuropsychiatric dysfunction, and there can be even development of pancreatitis in patients with the Sjögren's. Right? So neuropsychiatric dysfunction, and most commonly the neuropsychiatric disturbance can be in the form of delirium or delusion, and there can be also peripheral neuropathy very commonly seen. Right? So these are the systemic manifestations that you will come across in Sjögren's. And not only that, even there can be involvement of the kidney within the Sjögren's, and that involvement of the kidney will be in the form of type 1 renal tubular acidosis. See, type 1 renal tubular acidosis is that where the defect is in the distal part of the nephron, where there is impairment of the secretion of the H plus ion. H plus ion has to be secreted at the level of the distal tubule and it has to be excreted out. But because of the impairment, the H plus ion will get retained within the body, resulting in renal tubular acidosis. And this type 1 renal tubular acidosis in Sjögren's, it is seen in almost 20% of patients. And apart from that, there will be development of chronic interstitial nephritis, right? There will be development of chronic interstitial nephritis. This chronic interstitial nephritis, which may result in impaired kidney function, right? So this will cause a decrease in the kidney function. So that will be the renal manifestations in patients with the Sjögren's. Then followed by that, why these individuals with Sjögren's, they have dry vagina? So dryness in the vagina is due to involvement of Bartholin's gland. Right, it is due to involvement of Bartholin's gland. So because of the destruction of the Bartholin's gland, there will be dryness of vagina, and because of dry vagina, the individual will have a very painful intercourse, and that we call it as dyspareunia. Right, that we call it as dyspareunia. Right, so if you see this question now, Sicca syndrome is associated with all except midline granuloma, chronic active hepatitis, rheumatoid arthritis, scleroderma. So in Sjögren's, you can have the chronic active hepatitis, rheumatoid arthritis, scleroderma in secondary form of Sjögren's, but you don't have the midline granuloma. Next question. Primary extraglandular Sjögren's is seen in all except Rheumatoid arthritis, Raynaud's phenomenon, lymphoma, splenomegaly. Let me tell you, Sjögren's is also associated with extraglandular involvement. Just now we have discussed. And this extraglandular involvement, right, this extraglandular involvement, it is seen in almost 1/3 of patients. Now, what will be that extraglandular manifestations? Right, the most common extraglandular manifestation will be in the form of arthritis, right, and the other features include Raynaud's phenomenon, right, which is nothing but the peripheral vascular disease, then type 1 renal tubular acidosis, vasculitis, then there can be development of lymphoma, there can be involvement of lung, involvement of spleen, right, and there can be development of lymphadenopathy, right, and there can be mucositis, and this mucositis, it is the least common manifestation, right, mucositis, it is the least common manifestation in patients with the Sjögren's, okay, in the part of your extraglandular involvement. And not only that, this nervous system involvement, that is in the form of the peripheral neuropathy, right, and there can be also hepatomegaly as well. So these are all the extraglandular manifestations that you will have in patients with the Sjögren's. So the question is, primary extraglandular Sjögren's syndrome is seen in all except rheumatoid arthritis, Raynaud's phenomenon, lymphoma, splenomegaly. The answer is rheumatoid arthritis. See, you have to understand one point here, that we have discussed primary Sjögren's and secondary Sjögren's. Primary Sjögren's means only Sjögren's. Secondary Sjögren's means along with Sjögren's, other autoimmune disorders can be there. What is the question asked? Primary. So in primary, you will not have rheumatoid arthritis. It is in secondary, you will have the rheumatoid arthritis. Okay. Now, in primary, you have extraglandular manifestation, but that is arthritis, but it is not rheumatoid arthritis. So, is seen in all except the answer is rheumatoid arthritis. Raynaud's phenomenon can be there as a part of extraglandular manifestation. Lymphoma, splenomegaly can also be there. Next question. Uveitis is seen in systemic lupus erythematosus, Sjögren's syndrome, rheumatoid arthritis, and as well as the sarcoidosis. So, let me tell you, by seeing this word uveitis, don't jump onto the Sjögren's syndrome. It is not Sjögren's. Okay. So, uveitis, it is the clinical entity. So, uveitis, it's an acute presentation of sarcoidosis. Right, acute presentation of sarcoidosis. And what is another name of this uveitis? This is also called as Hereford syndrome. Right, this is also called as Hereford syndrome, and it is an uncommon acute presentation of sarcoidosis. And these individuals, they can also have the presence of fever. There will be parotid and lacrimal gland enlargement. Next, there can be uveitis, right, and there can be bilateral hilar lymphadenopathy that you will see, that is a characteristic feature in patients with the sarcoidosis, and even there is cranial nerve involvement, and that will be in the form of cranial neuropathy. So which cranial nerve is affected? That is the 7th cranial nerve is affected in the sarcoidosis. Okay. So uveitis, let me tell you, it is one of the close differential diagnosis of the Sjögren's syndrome. Right. It is a close differential diagnosis of the Sjögren's syndrome. Right. So even in case of uveitis, there is involvement of the lacrimal and as well as the salivary gland. Right, there is involvement of lacrimal and as well as the salivary gland. Okay, next. Now, how will you differentiate them? Right? So let me just show you a table of differences between the Sjögren's and sarcoidosis. See, Sjögren's, usually the age group is around 40 to 60 years. But sarcoidosis, right, it is invariable, right? It can be seen at any of the age group. And in Sjögren's, it is an autoimmune disorder. So you have the presence of the autoantibodies. Whereas in sarcoidosis, right, you don't have the autoantibodies. And how will you confirm and how will you differentiate both of them? By doing the biopsy. So when you do a biopsy in Sjögren's, biopsy, it will show you the presence of CD4 plus T lymphocytes in Sjögren's. Whereas in sarcoidosis, you have the presence of non-caseating granuloma. Right, you have the presence of non-caseating granuloma. Okay, so that is what is the difference between the Sjögren's and as well as the sarcoidosis. So, if you see this question here, uveitis is seen in, what is the answer here? The answer is sarcoidosis, right? It is not your Sjögren's syndrome. So, the next question, if you see, bilateral parotid gland enlargement occurs in all except Sjögren's syndrome, systemic lupus erythematosus, sarcoidosis, chronic pancreatitis. Okay, let me discuss all the conditions where you have bilateral parotid gland enlargement and then we will come back to this question. So, bilateral parotid gland enlargement, it is seen in viral infections. So, which all viral infections are responsible for this bilateral parotid gland enlargement? Number 1, Epstein-Barr virus. Then we have Coxsackie-A virus, then cytomegalovirus, HIV, next we have mumps, and next influenza. So these are all the viral infections where you can have the bilateral parotid gland enlargement. Then followed by that, you take the metabolic causes for bilateral parotid gland enlargement that you will have in patients with diabetes mellitus, then in patients with cirrhosis of liver, next also seen in patients with chronic pancreatitis, and other condition is in hyperlipoproteinemia. So these are all the conditions, metabolic causes for bilateral parotid gland enlargement. Next, the endocrine causes for bilateral parotid gland enlargement will be acromegaly, where there is increase in growth hormone production in adults. Right, and then gonadal dysfunction. So these are all the endocrine causes for bilateral parotid gland enlargement. Then followed by that, in sarcoidosis you will have bilateral parotid gland enlargement, right? And even in patients with amyloidosis, right, you will have bilateral parotid gland enlargement. So if you see this question now, bilateral parotid gland enlargement occurs in all except Sjögren's, definitely it will occur, that is what we are discussing now. Sarcoidosis, there is bilateral parotid gland enlargement. Chronic pancreatitis, also there is bilateral parotid gland enlargement. But in patients with the systemic lupus erythematosus, bilateral parotid gland enlargement is not seen. So that is about the clinical scenarios where you have bilateral parotid gland enlargement. Now let me discuss the diagnosis of the Sjögren's syndrome. When you do a complete blood picture in patients with the Sjögren's syndrome, that will show you the presence of mild anemia, then followed by that leukopenia, right, where there is decrease in the WBC count, right, and there will be eosinophilia, right, there is increase in the eosinophil count. So this will be the complete blood picture in patients with the Sjögren syndrome. And if you take the antibodies, right? So because it is associated with other autoimmune disorders also. So RA factor can be positive and anti-nuclear antibody can be positive because it can be associated even with the systemic lupus erythematosus as well. So that is the reason why the anti-nuclear antibody can be positive. Okay. Now the antibodies of Sjögren's as such, right, that is SSA and as well as SSB, right. So these two antibodies, they are like very commonly seen in patients with Sjögren's, but it is seen only in 90% of patients with the Sjögren syndrome. Okay, right. And associated autoimmune disorders, whatever are there, you can have those associated antibodies as well. Like you take rheumatoid arthritis, or you take in SLE, or you take Hashimoto's thyroiditis, the respective autoimmune antibodies will be there. Now, apart from that, the other very important diagnostic test in Sjögren's will be the Schirmer's test. See, in these patients with Sjögren's, what we have discussed, there is decrease in the tear production. Right, there is decreased tear production, and that is being demonstrated by the Schirmer's test. So this Schirmer's test, let me tell you, it is performed without anesthesia. Right, it is performed without anesthesia, and you have to keep a blotting paper, right, which should be hanging over to the lower eyelid. Now, when the blotting, if it is less than 5 mm in 5 minutes, right, if the blotting is less than 5 mm in 5 minutes, that is considered to be the Schirmer's test to be positive. Okay, so this is the Schirmer's test, which will show you that there is decreased tear secretion in patients with the Sjögren's. Next, another important test is the cylometry. Now, what is this cylometry demonstrate? Even the cylometry will demonstrate decreased production of saliva. Schirmer's test were demonstrating the decreased tear production, but whereas cylometry, it will demonstrate decreased salivary production. Okay, that is about your cylometry. And cylometry, what exactly is this? It is the one which will measure the salivary flow. That is what is your cylometry. So cylometry will demonstrate decrease in the salivary production in patients with the Sjögren's. Then, if you take the MRI or magnetic resonance psilography of the major salivary gland, that will demonstrate the presence of abnormalities. Right, MRI or magnetic resonance psilography of the major salivary glands may also demonstrate the abnormalities. But what is the investigation of choice, or what is the test which will confirm the diagnosis of the Sjögren's? The one which will confirm the diagnosis of the Sjögren's will be biopsy. Right. So you take a lip biopsy, right, which is a simple procedure. Okay. Lip biopsy, a simple procedure, it reveals characteristic lymphoid foci in the salivary glands. Okay. So you have the presence of lymphoid foci in the accessory salivary glands, and even biopsy can be done from the parotid gland. Right, even the biopsy can be done from the parotid gland. So biopsy of the parotid gland should be reserved for patients with atypical presentation. Right, in those individuals with atypical presentation, in them you need to do biopsy of the parotid gland. Right, now what is that atypical presentation? See, in patients with Sjögren's, it is bilateral parotid gland enlargement, but atypical presentation, it can be in the form of unilateral parotid gland enlargement. So that will be atypical presentation, because unilateral parotid gland enlargement, it is suggestive of neoplastic process. So if you are in a doubtful scenario, you need to do a parotid gland biopsy. Right, and the single most sensitive and specific test for the diagnosis of the Sjögren's is biopsy, which will reveal the lymphatic infiltration of the salivary glands. Then, after having discussed about the biopsy, let me discuss the complications in Sjögren's. See, in Sjögren's, one of the very important complication that can be seen is development of lymphoma. Development of lymphoma in Sjögren's is suggested by all of the following except persistent parotid gland enlargement, cryoglobulinemia, leukopenia, high C4 complement levels. Now, let me discuss the lymphoma in patients with the Sjögren's. See, lymphoma, it is one of the well-known complications of the Sjögren's syndrome. And what is the type of lymphoma that you will have in patients with the Sjögren's? It is an extranodal extranodal, low grade, marginal B-cell lymphoma. Extranodal, low grade, marginal B-cell lymphoma. That is what you will have in patients with the Sjögren's syndrome. That is a complication that is being anticipated. Now, the development of lymphoma, the development of lymphoma in patients with the Sjögren's syndrome is suggested by the following features. Number 1, persistent parotid gland enlargement. Persistent parotid gland enlargement. Number 2, development of purpura. Number 3, leukocytosis, that is increase in the WBCs. Number 4, I'm very sorry, this is a repeat. Number 3, leukopenia. Number 4, cryoglobulinemia. And number 5, low C4 complement levels. Low C4 complement levels. Okay, so these are the features that tells you that there is increased chance of development of lymphoma in patients with the Sjögren's syndrome. So if you see this question now, development of lymphoma in Sjögren's syndrome is suggested by all except the answer is high C4 complement levels does not tell you development of lymphoma. It is low C4. And remaining all, they are true, Persistent parotid gland enlargement, cryoglobulinemia, leukopenia. All these will tell you that there is chance of development of lymphoma in patients with the Sjögren's. Now, we have a classification criteria for Sjögren's, and we have a revised international classification criteria for Sjögren's. And according to this, the individual should definitely have the presence of the ocular symptoms, that is in the form of dry eyes, burning sensation within the eyes, itching sensation within the eyes. Next, oral symptoms, where the individual will have dryness of mouth, difficulty in speaking, difficulty in swallowing. Then ocular signs, not only ocular symptoms, the ocular signs, that ocular signs wherein the Schirmer's test should be positive. Okay, so we have discussed when will we call this Schirmer's test to be positive, This Schirmer's test has to be performed without anesthesia, and if the blotting is less than 5 mm in 5 minutes, then we consider the Schirmer's test to be positive. Then followed by that, the salivary gland involvement. Okay, so in the salivary gland involvement, if any one of it is positive, that is also taken into the criteria, What is that? If unstimulated, please remember this, unstimulated, unstimulated salivary score if it is less than 1.5 ml in 15 minutes, right? Less than 1.5 ml in 15 minutes, right? That is one. Second, parotid scilography. Okay, so the scilography or sciometry will show you that there is decreased salivary secretion. And then salivary scintigraphy. So out of these three, right, out of these three, if any one is positive, that is taken into the criteria. And lastly, the antibodies in the serum, that is anti-Rho and as well as the anti-La. So totally we have discussed 6 features: ocular symptoms, oral symptoms, ocular signs, that is the Schirmer's test has to be positive, then the salivary gland involvement, that could be any of these three, and then the antibodies, right, that is anti-Rho, anti-La. So out of these, minimum 4 out of 6 should be there. Antibodies, we have discussed 2 antibodies. Anti-Rho is one antibody, anti-La is the other antibody. So this will be 5 and this will be 6. Okay, so 4 of 6 is positive, then we consider it to be Sjögren's. And the other thing is, even the histopathology also must be positive. Now, after having discussed about the criteria for diagnosing Sjögren's, what is the composition of saliva in Sjögren's syndrome? Composition of saliva, it shows increased salivary IgA, right? Number 2, increased salivary sodium. Number 3, decreased salivary phosphate, right? Number 4, reduced stimulated and unstimulated salivary flow rate. Okay, so there will be reduced salivary flow. And see, what do you understand by this word reduced salivary flow, which we are discussing from the beginning? If you take the normal flow rate, right, the normal flow rate of saliva is around 1 to 2 ml per minute. That is a normal flow rate of the saliva. When will you call reduced salivary flow? When the salivary flow is less than 1.5 ml in 15 minutes. Right? If the salivary flow is less than 1.5 ml in 15 minutes, that we call it as decreased salivary flow. So this is about the composition of saliva in Sjögren's syndrome. Then, having discussed about the diagnosis, criteria and composition of saliva, let me tell you what are all the various differential diagnoses for the Sjögren's syndrome. See, this dry mouth, it can be seen as the side effects of the drugs. Right, it can be seen as an adverse effects of certain drugs like atropine and all, right? It will cause dry mouth. Then another important thing is the chronic hepatitis C infection. This hepatitis C infection, it can cause Sicca symptoms. Right, it can cause the Sicca symptoms. Right, hepatitis C has to be ruled out. Okay, and the other disorders which is taken into the differential diagnosis is in HIV infected individuals, right, in HIV infected individuals, there is infiltration of CD8 T cells, right, there is infiltration of the CD8 T cells, and because of the infiltration of the CD8 T cells, there can be parotid gland enlargement. That is one of the other important differential diagnosis. Okay, next, the other important differential diagnosis just now we have discussed in the same session previously, that is uveitis, that is sarcoidosis is another important differential diagnosis. Then IgG4 related systemic disease. right? IgG for related systemic disease. So these are the differential diagnosis for your Sjögren syndrome. Now, having discussed, let me tell you the treatment of the Sjögren syndrome. See, the treatment of Sicca symptom is symptomatic and supportive. Right? What is that conservative or supportive treatment? Like for example, if the individual has dry eyes, right, that is ocular symptom, you need to give artificial tears. Right? You need to give artificial tears. And apart from that, topical ocular cyclosporin. Right? Topical ocular 0.05% cyclosporin. Right, so this topical ocular cyclosporin, this also improves the ocular signs and as well as symptoms of dryness. Okay, so even this will reduce the signs and symptoms of dryness in patients with the Sjögren's. And this cyclosporin is available by prescription to help the treatment of the chronic dry eye. And what this cyclosporin will do? Cyclosporin will suppress the inflammation, right? Will suppress the inflammation that disrupts the tear secretion, right? It will suppress the inflammation that disrupts the tear secretion. Okay, and that is regarding the ophthalmic manifestations. And if you take the oral manifestations, the mouth should be kept well lubricated, right? And for which the sipping of water, this sipping of water should be done frequently. And apart from that, pilocarpine. So this pilocarpine 5 milligrams orally, right? Pilocarpine 5 milligrams orally 4 times daily. Right? Pilocarpine 5 milligrams orally 4 times daily. And acetylcholine derivative, that is cevimeline. Right? Cevimeline, it is an acetylcholine derivative. So pilocarpine and as well as the cevimeline. And what is the dosage of the cevimeline? That is around 30 milligrams orally. That should be given thrice daily. Right? That should be given thrice daily. So this pilocarpine and as well as cevimeline, which is an acetylcholine derivative, will improve the xerostomia symptoms. And you have to remember that in Sjögren's, there are certain drugs that has to be avoided. What are the drugs that have to be avoided in Sjögren's? That will be atropinic drugs. Right? Atropine and as well as atropine derivatives have to be avoided. And even the decongestants. Okay, so atropinic drugs and decongestants, both of them, they decrease the salivary secretion and they should be avoided, right? Both of these drugs, they decrease the salivary secretion. Now, the other important thing is how to preserve the dentition in patients with the chronic Sjögren syndrome. See, in patients with Sjögren's, the dryness of the mouth may predispose to the impairment of the dentition. So, a program of the oral hygiene, right? A program of the oral hygiene, including the fluoride treatment, right? Including the fluoride treatment is very much essential in order to preserve the dentition of the individual. And for suppose if there is associated rheumatic disease, its systemic treatment is not altered by the presence of Sjögren's. You have to treat that rheumatic disease. Okay, and if there is presence of the extraglandular manifestation. So I have discussed that in almost 1/3 of individuals there will be extraglandular manifestations. So all these extraglandular manifestations like arthritis, vasculitis, pulmonary manifestations, they are treated with similar immunosuppressive medications as SLE or rheumatoid arthritis. Okay, next. Now, I said you because of the destruction of the Bartholin's gland, there can be vaginal dryness. So in women with Sjögren syndrome, the vaginal dryness that can be treated by lubricants, personal lubricants. Right, that can be treated by personal lubricants. And just now we have discussed if there is arthritis, that is if there is musculoskeletal manifestations, NSAIDs may be given. Right, non-steroidal anti-inflammatory drugs may be used to treat the musculoskeletal symptoms. And in those individuals with severe complications, right, in those individuals with severe complications, steroids or immunosuppressive drugs have to be given. Right, steroids or the immunosuppressive drugs may be prescribed. And sometimes intravenous immunoglobulin has to be administered. So that is about the musculoskeletal symptoms. For suppose if there is presence of systemic manifestations like the presence of neuropathy, myositis, arthritis, fatigue. So if there is presence of systemic symptoms, then you need to give biological immunosuppressant drugs. Right, biological immunosuppressant drugs. And these biological immunosuppressant drugs, they include rituximab, and other very important drug, that is belimumab. Right, so rituximab and as well as belimumab, both of them, they work via B-cell pathology. Right, they work via B-cell pathology. So that is about the treatment of systemic symptoms in patients with the Sjögren's. Then how is the prognosis in these individuals with Sjögren's? Although Sjögren syndrome may compromise the patient's quality of life significantly, the disease is usually consistent with normal lifespan. Right, normal lifespan. But the quality of the life is being compromised. Now, there are certain poor prognostic factors. Now, what are those poor prognostic factors seen in Sjögren's? Right, they include the presence of lymphocytic vasculitis. Right, mainly if the individual has extraglandular manifestations, then the prognosis is poor. Right, or if the individual is having the development of peripheral neuropathy, and if the individual has the development of complication of lymphoma. So if these features are there, then we consider that the prognosis of the Sjögren's is very, very bad. Right, now the patients at greatest risk of developing lymphoma, right, we have discussed. The patients at greatest risk for developing lymphoma are those with severe exocrine dysfunction, marked parotid gland enlargement, splenomegaly, vasculitis, peripheral neuropathy, mixed monoclonal cryoglobulinemia. So these are the group of individuals who are at greatest risk for development of lymphoma, right? Having discussed about the Sjögrens in detail, let me tell you what are the essentials of diagnosis. So women, they are more prone for Sjögrens than compared to that of men. Almost the ratio is 9:1, and the average age group is around 50 years. And the classical symptoms, that is Sicca component, that include dryness of eyes and as well as the dryness of mouth. These are the most common features, right? Either they can occur alone, that is primary Sjögrens, or they can be associated with the rheumatoid arthritis or other connective tissue disorders. That will be your secondary Sjögrens, right? So rheumatoid factor and as well as anti-nuclear antibodies are common, and there is increased incidence of the lymphoma. So these are the essentials for the diagnosis of the Sjögren's syndrome. So after having discussed about Sjögren's, let me discuss some clinical scenarios related to your Sjögren's syndrome. So I have a 57-year-old woman with depression and chronic migraine headaches, reports several years of dry mouth and as well as dry eyes. Her primary complaint is that she can no longer eat her favorite crackers, although she does report photosensitivity and eye burning on further questioning. She has no other associated symptoms. Examination shows dry, erythematous, sticky oral mucosa. All of the following tests are likely to be positive in this patient except SSB antibody, SSA antibody, Schirmer's test, SCL70 antibody, cytometry. So this is a classical case of the Sjögren's syndrome, right? No doubt in that. So the antibodies, what you will have is anti-Ro and as well as anti-La. The Schirmer's test will be positive, and cytometry shows decreased salivary flow. But SCL70, it is suggestive of the scleroderma. And what the question says no other associated symptoms. So it is a case of the primary Sjögren's, and in a case of primary Sjögren's, you don't have the SCL70 antibody being positive. SCL70 antibody could be positive if it is like secondary Sjögren's, because secondary Sjögren's you can have association even with scleroderma as well. So the answer to this particular question is the fourth option, that is D. Now, after having discussed, you see the next question. A patient with primary Sjögren's syndrome was diagnosed 6 years ago and treated with tear replacement for symptomatic relief. He notes continued parotid swelling for the last 3 months. She has also noted enlarging posterior cervical lymph nodes. Evaluation shows leukopenia and low C4 complement levels. What is the most likely diagnosis in this patient? Amyloidosis, chronic pancreatitis, HIV infection, lymphoma, secondary Sjögren's syndrome. So, in spite of treatment, there is persistent parotid gland enlargement. There is posterior cervical lymphadenopathy, leukopenia, and low C4 complement levels. All these, they favor in the development of complication of lymphoma in patients with the Sjögren's syndrome. So lymphoma, it is a well-known complication that you will have in patients with the Sjögren's, right? And that too, what type of lymphoma? It is extranodal marginal B-cell lymphoma, right? So that is about the, and how do you treat this particular lymphoma? So the initial treatments are bendamustine plus rituximab. Okay, if you see the treatment here, right? So the initial treatment are bendamustine plus rituximab and the R-CHOP regimen, that is rituximab, cyclophosphamide, doxorubicin, vincristine and prednisolone. So these are used to treat the slow growing lymphomas such as the follicular lymphoma, right? Next, last question. A 43-year-old Japanese woman presents to your clinic with 6 months history of dry irritated eyes, dry mouth, cheek swelling. On examination, she has parotid gland enlargement bilaterally. Cytometry is abnormal. Biopsy of the minor salivary gland in the lips shows granulomatous inflammation. Serology show a negative SSA and SSB antibodies. Which of the following is the most likely diagnosis? Systemic sclerosis, sarcoidosis, Sjögren's syndrome, HIV associated Sicca syndrome, eosinophilic granulomatosis with polyangiitis. So here the answer is sarcoidosis. Now why is that it is not being a Sjögren's syndrome? You see the biopsy, what does it show? Shows the presence of granulomatous inflammation, which is suggestive of sarcoidosis. And if it is a Sjögren syndrome, you have the presence of CD4 plus T lymphocytes within the biopsy. And not only that, in Sjögren syndrome, the antibodies should be usually positive. 90% of individuals, they'll have positive antibodies. So it is not Sjögren syndrome here. The answer is sarcoidosis. I have said you, the close differential diagnosis of Sjögren's will be your uveitis, which is nothing but Hereford syndrome. And what is this particular Hereford syndrome? It is nothing but acute presentation of the sarcoidosis, right? Acute presentation of sarcoidosis, right? And if you see the next question, which of the following is the most common extraglandular manifestation of primary Sjögren's? Arthritis, lymphoma, peripheral neuropathy, Raynaud's phenomenon, vasculitis. So the answer to this question is arthritis, right? That is the most common extraglandular manifestation. And for this particular arthritis, we give NSAIDs. And what is the least common manifestation? Least common manifestation will be mucositis. Okay. So that is about your Sjögren syndrome, right? So we have discussed in detail about the Sjögren's differential diagnosis and important multiple choice questions related to the topic. Thank you very much.